I'm Dr. Gary Kraus, neurosurgeon and founder of the Kraus TBI Institute in Houston, Texas. The Kraus TBI podcast video provides knowledge and education about traumatic brain injury and makes the invisible side of mild TBI visible. We all utilize every day what is likely one of the most complex machines in the universe, the brain. Let's try to understand how we work. We're dedicated to creating videos and podcasts to deepen learning, and we'll have on our show clinicians, researchers, scientists, and those who have themselves suffered a mild TBI. Brain injury can happen as a result of many types of causes. In the civilian population, non-military, most common is falls, but also motor vehicle collisions. The head can strike an object or be struck by an object, but just a mere acceleration, deceleration is sufficient to cause an injury to the brain. There can be shearing forces, rotational forces, others. In the military population, blast injuries are the most common. And interestingly, what people may not recognize is that, and we do see blast injuries in the civilian population as well, and especially in Houston, I've seen a number of patients that have experienced explosions from different plants, etc. But the blast injury does not require a mechanical object to strike the patient. Now, I have had patients who have had blast injuries when the explosion happened, even maybe half a mile away, and then part of the ceiling fell on their head or something of that nature. So that is mechanical, but just the blast injury itself, there's something called a BOP, a blast overpressure wave. Just that wave of air is enough to cause damage to solid and hollow organs in the body. Now, after a patient has an injury, they may have had an acceleration, deceleration, some other, and they may not even recognize that they've had an issue. I think it's important for them and families to be aware of this. There are some conditions that we have when changes are subtle that we recognize a change in somebody, but we don't attribute it that this could be as a result of this injury. Patient may have some subtle changes. They may have balance difficulties. They may be more irritable, get annoyed. I see that often. I see balance issues often. They may have confusion, inability to multitask, having trouble at jobs, other tremendous number of lists of what we call symptoms after an injury, or post-concussive symptoms. The Department of Defense criteria for a mild traumatic brain injury don't require loss of consciousness. It's enough to have had disorientation, other changes, forgetfulness, what's called post-traumatic amnesia for the event, for some of the aspects after the injury. Those are sufficient to have shown that the brain did undergo some jarring and some changes. Often it's not recognized. I remember a little while back, I was evaluating a patient for neck and back pain. And the patient was there, a nice gentleman, and his wife was in the room. And I was palpating the neck, and he described where it was tender, going through range of motion evaluation. As I was about to palpate and touch the low back, he turned around very aggressively and suddenly said, "If you touch my back, I'm going to kill you." So I, of course, didn't want that to happen. I pushed my chair away and I looked at his wife and I said, is your husband always so aggressive like that? And she said, "No, he was nice. He's never been at all like that. Since the injury, he's very angry, very aggressive all the time, suddenly for no reason." So clearly, I think it seems that we can conclude that he did suffer a traumatic brain injury of some, but I was asked to see him purely for neck and back, and I don't think that he or anybody had recognized that it was also probably a traumatic brain injury as well. So a lot of times it is unrecognized. The other thing is that people may not want to discuss it or realize that they've had an injury, a change in the brain. It's very sensitive, it's very personal. I mean, if I have something going on with my foot, yes, it's personal too, but it's my foot. But if I say, there's something with my brain, I can no longer process correctly, I can no longer think, I can no longer focus. I've had patients say that it's embarrassing for them They're afraid of losing their job if people realize that they can't function properly. They're embarrassed that they aren't functioning properly for their children, remembering things. They emphasize to the children, no, it's not that you're not important to me. I keep forgetting, though, things that I have to do. I keep forgetting things you're doing. I've had people tell me they have to write sticky notes and Post-it notes all over. They've had boards, eraser boards in different rooms where they write things down. I've had patients tell me they put it in their phone, but then they forget to check their phone, so they put it all over their house. Many mechanisms to try to compensate, but they also feel bad. They feel worried. They feel embarrassed. They feel worried about losing their job. And that's a natural worry. It's a natural feeling. None of us wants to think our thinking has diminished, our intelligence has diminished. We're no longer the same person. We can't judge things properly. We can't make decisions. We're not capable of. None of us wants to think that. So a lot of times they may not recognize it themselves. So it's something that we should all be aware of. We should all be supportive. And the more and more we become educated, we can recognize these things early. It might be after an injury that somebody, for instance, a motor vehicle collision, somebody might ask, I say, are you okay? Well, I guess somebody might say, well, if I'm up, I'm walking, talking, I'm okay. But they may not recognize the change, and they may not even notice it. There may be changes that happen in a delayed manner. And they thought they're okay, but they're not okay. So as I say, it's very important that the more education, the more recognition of these symptoms, the better we can understand, better we can treat brain injury. One thing that is unfortunate is terminology. Now, definitions are important because that's how we describe things. If I say it's a hot day out, but I mean it's cold, well, I'm going to dress with the wrong kind of clothes. If I say it's rainy, but it's sunny, I'm going to, I'm going to bring an umbrella when I didn't need it, and vice versa. So if I say something is a mild TBI or mild traumatic brain injury, mild I generally think of as what we would commonly think of mild. I have mild hot sauce. I can eat it. I don't have to worry. It's not like a habanero. Mild weather. It's not going to be severe thunderstorm, hail, anything worrisome. I don't need to worry. When it comes to TBI, unfortunately, we have the term, one of the classifications is mild. We have mild, moderate, and severe. Mild does not necessarily mean mild, and it's unfortunate that we have this designation. Mild can mean possibly we might be classified as a mild TBI, but still have permanent, debilitating, lifelong difficulties that affect our work, our thinking, our emotions, our behavior, our cognition, our intelligence, our personal interactions with others, our satisfaction in life, our happiness, our moods, all of this as a result of a mild TBI. It's possible. So we unfortunately have this term, but we have to get past being held captive by a term, mild TBI. We have to recognize that it may be severe lifelong complications that dramatically affect the individual and everyone around them. At Kraus TBI Institute, we treat patients as a whole. We see patients that have a variety of issues concerning them. We see patients from the day after they've suffered an injury. We see patients 3 years after they suffered an injury. Many times I find that somebody's been seen in an emergency room. They had some concerns. They had some issues. They were discharged. They may have suffered a mild traumatic brain injury, but it wasn't diagnosed. And either a short time will go by or a long time goes by. And their care has been kind of fragmented. They've had various providers. The care has not been coordinated. And providers haven't talked to each other. What we focus on is treating the patient not just for the injuries, but as a whole person. So if somebody's been involved in an injury recently or even a long time ago, a brain injury may have been sustained. Other aspects may be, if we're neurosurgeons, so if they have neck or back pain, we do the full spectrum of treatment from conservative measures. We can get coordinated some therapy, injections, whether they be epidural injections, facet injections, sacroiliac joint injections. We also can proceed with surgical approaches such as surgeries in the neck, back, fusions, artificial discs. But we also can coordinate care for other body parts. If they have hips, knees, shoulders, other things like that we can do. But in addition, we can look at the patient as a whole, and if they've been having symptoms, such as symptoms of a mild traumatic brain injury, we can evaluate that. We take the time that's needed to try to evaluate it. It may be over a couple of visits. We can get additional testing done as needed. We can get additional consultation done as needed. But we want to try to figure out what is the source of some of the changes. Was it related to an injury? Are there things we need to watch out for? And are there treatment measures that we can implement to try to improve injuries to the brain? And we'll do our very best to try to improve as much as we can, but ultimately we want our patients to be happy as much as possible, satisfied with the care. And if some of it is compensatory mechanisms, some of it is cognitive rehabilitation, etc., if some of it is adjusting to a new normal, we want to take all of that into account and do the best to help our patients in every aspect. What I advise patients is after they've suffered an injury, get evaluated. If there's a concern, be on the safe side, be evaluated, go to an emergency room, see a doctor, get their thoughts. Now, as we discuss in many aspects of our podcast videos, we all recognize very well, or relatively well, injuries to back, neck, shoulders, knees, hips. But traumatic brain injury, especially mild, is less recognized. And I see very frequently people go to emergency room, get discharged to follow up perhaps with various specialists for different body parts. But usually if it's a mild TBI, it's not recognized and nothing's done. So I do recommend getting evaluated by people who know what to look for. Sometimes it's difficult to advise. I don't know specifically in different regions and cities and parts of the country. There may be different level of expertise and different people looking at different areas. But the way we approach it at Kraus TBI Institute is we want to try to assess for all areas of the body, get proper diagnoses, get proper consultations, get proper evaluations, and do our best to diagnose and whatever we can do to treat traumatic brain injury as well. So we get involved in the care of patients at all aspects. We sometimes see a patient a day after an injury. We sometimes see patients 3 years after an injury. We see patients from Houston. We can see patients from any location. We're happy to try to help in any way we can and assess and diagnose and treat to the best of our abilities. And even if an injury has been several years ago, although we strive to treat and evaluate as soon as possible, even if it's been a while, we're happy to take care of patients as we do and do our best to diagnose and treat people with various injuries, even if it's been a while since an injury. So when a patient has suffered an injury and they go to emergency room, the goal of the emergency room is initially to make sure a patient is going to have any dire consequences. Is there anything life or limb threatening? So if there's a severe fracture that may need an emergency operation, if there's bone protruding through the skin, if there are other issues that are life or limb threatening, if there's a hemorrhage in the brain that threatens a patient's survival, may need an emergency operation. So that's the main goal of the emergency room, to diagnose, do an assessment, and make sure we're not missing anything life or limb threatening. After that, If it's something the patient can be discharged and taken care of on an outpatient basis, they may be asked to follow up with various specialists. It may be for a neurosurgeon, it may be a pain specialist, maybe an orthopedic surgeon, maybe various types of physicians. Where I find sometimes falls through the cracks is brain injury, because the standard test or evaluation used in emergency rooms around the world since the 1970s is known as the Glasgow Coma scale. So this is a standardized scale in which it's used to assess the level of consciousness of a patient. Now, this is helpful for somebody in an emergency situation. If they have a hemorrhage in the brain and we may need to rush to the operating room, we may need to talk with colleagues or the ICU, different units in the hospital. How's the patient doing? We will report how the Glasgow Coma scale is, and it gives us a standardized estimate about neurological function. But it's not good for the assessment of mild traumatic brain injury. And unfortunately, after somebody does suffer mild traumatic brain injury, they may be discharged to see various specialists after the injury for other body parts. They may be seeing somebody for neck, for back, for shoulder, for hip, knee. But in my experience, often the mild traumatic brain injury issues may not necessarily be addressed. And it's often not in the scope even of the emergency room to do a detailed evaluation, because the questions are lengthy, the evaluation is detailed, and the patient has just suffered an injury that day. The emergency room is stabilizing and then referring or operating and taking care of any emergencies. But somehow I find that mild TBIs often kind of fall through that crack. So we find that we take care of patients, either they've had an injury yesterday, we can help to coordinate everything, which we do very frequently, or they've had an injury a long time ago, but some aspects have just not been addressed. So that's when we get involved in the care, and we can try to either fill in the gaps for what hasn't been addressed, and especially trying to evaluate further the brain injury and get diagnosis and treatment, or very early on in the stage. But that's at Kraus TBI. We're really interested in taking care of the patient as a whole. And sometimes this does take a lot of detailed evaluation. It may happen over more than one visit. We may get consultants involved. The other aspect that we find is that I do sit down with patients and I explain to them that healing of a brain injury is different than healing of a fracture or healing of a herniated disc or so. It's not the sort of thing where a physician might go in, do a procedure, fix it, the wound heals, and then it's better. With the brain injury, it's different. It's not something we can just go in and fix. We can do other types of rehabilitative mechanisms. We can do other types of treatment. We have diagnostic tests. But it's something where a patient participates with us and with other providers in trying to participate in their healing. It's not an instant process. It does take time. But a lot of it takes understanding and education to recognize that, again, the brain is different than any other body part. Its healing is different than any other body part. And we understand that, we recognize that, and we would like patients to recognize that, and we want family members and all those around the patient to recognize that.